In fact, for thrombectomy decision, the current guidelines only approve a thrombectomy for patients with a small cores, with a very large vessel occlusion and high NIHSS. And typically in this situation, all the patients have a mismatch, have a penumbra. So perfusion is not useful in this population because all the patients have a mismatch. But in other situations where the benefit of thrombectomy is currently unknown, such as patients with large cores, we do not know if thrombectomy is beneficial or not. And I strongly believe that perfusion imaging, some of this, when we take, a population with large core, roughly 2/3 of this population have a mismatch, but one-third of this population does not have any mismatch. And our hypothesis was that only the population with a mismatch have some benefit of endovascular therapy. So this was only a retrospective observational study comparing large core patients treated either with medical management alone or with endovascular therapy, and all of the patients had perfusion imaging, and we compared the effect of endovascular treatment as compared to medical management alone in the group of patients with perfusion imaging, and also is a group with a mismatch on perfusion imaging, and in the group of patients without. And we found that in patients without mismatch there was no benefit of endovascular therapy, but there were higher risk of complication, namely intracranial hemorrhage. And on the opposite, in patients with a significant mismatch, there was a huge benefit of endovascular therapy despite a higher risk of intracranial hemorrhage. So clearly, perfusion imaging in this type of situation could allow to do personalized medicine and to treat only the patient for which the treatment may be beneficial.